Good evening, guys and girls, colleagues, ladies and gentlemen. Thank you very much for joining us in this live surgery webinar where we plan to do ALL-ON-4, upper and lower. So if we can just focus on this panoramic X-ray. Can we see the panoramic X-ray? The plan is to do a maxillary clearance. In other words, extract 1, 2, 3, 4, 5 maxillary teeth and place 4 implants in the maxilla and then place 4 implants in the intermental region of the mandible. Nikos, can I make the plan on the panoramic or not yet? Yep. Okay, so if we have a look here, we will place the first implant starting top right, position number 16. So here is our first implant. The second implant will probably be position 13. Okay. Then we're going to go position 22. And we'll go position 24 at an angle so that we can avoid the maxillary sinus. And on those 4 implants, we will then take an impression for immediate loading, and we're going to place 12 teeth. 1, 2, 3, 4, 5, 6 on the one side. 1, 2, 3, 4, 5, 6 on the other side. The important thing is to avoid teeth number 21 because there's a periapical radiolucency, and we're going to probably avoid tooth number 12 because we also have a defect there. Then we're going to move over to the mandible, and we'll place the 1 implant in position number 45 and 1 implant in position number 35 at a slight angle to avoid the mental foramina, and another 2 implants in the lateral incisor areas. 4 implants, we will place 12 teeth. Something like that. That's our plan. Okay, so let me take this out of the way. And let's proceed. We're going to start with the upper jaw. The reason being that the most important tooth for the facial aesthetics and harmony is the central incisor, so we always start with the upper jaw. Okay.
Okay, good evening from my part. I'm Petros, the prosthodontist. Here's our patient, Miss Maria. On the bottom jaw, she's wearing a complete denture. On the top jaw, she's having a removable partial denture and some fixed prosthodontics. She was not happy with the length of her teeth. The midline was completely off. So what we did, like an hour ago, we added some composites. Composite fillings. We did some composite veneers on her pre-existing porcelain work in the front. So we lengthened her teeth, and also we corrected the midline. So now we can start having something more solid to work with. So Dr. Costa is giving the anesthesia.
You can see the denture
stomatitis
from the partial denture. So we'll all be happy to get rid of this denture. Kliste parakalo, bite, kliste, that's it. Okay. Anichte. So let's have the denture again. One more very important thing that we're going to do before we start extracting teeth is make a surgical guide. Kliste parakalo. And the surgical guide we make with a fast setting, hard silicone material, bite registration type material. Okay, it'll take about 40 seconds to set, and that's our surgical guide, which you will see how useful it will be during placement of the implants.
So basically, before we establish the midline and the plane of occlusion that we want, especially from the right-hand side, which was very short, and now with that silicone key, Dr. Costa will know exactly where to place the implants, which position and which inclination.
A few more seconds for this to set.
This material is becoming extremely hard, so it needs to be removed before complete setting.
Aniksta parakalo, thank you. There you go.
While
So what we do now, the important thing is to cut this in such a way that we see the buccal outline, so we can see that there's number 13, there's number 14, there's number 15. Okay, let me just remove this. I'll come back in a moment.
So I can show you what we did on the lower jaw. This is the denture that she's wearing. We know that we're going to place the teeth, the implants, in the position of the lateral incisor and in the position of the tooth number 5, 45, and 35. So we open some holes here through which Dr. Costa is going to start making, he's going to start making the osteotomies in order to place the implants.
Okay, so here is our surgical guide. And we know that over here is tooth number 13, right here. And we don't want the access hole to be like the angle of the implant to be like that. We want it to be like that, the prosthetic angle, of course. And we're going to use some angled implants to get our access holes in the palatal position. So this is tooth number 13, right there. Okay, let's take this out. And let's have a look. There's my mark. That's tooth number 13. If you remember, we said we'd like to possibly avoid 11. That's 13 there. Okay, 13, 16. Before I decide on 13, I just want to extract tooth number 12 and see if it might be a suitable position. So what I'm using now is a speed increasing handpiece on my surgical motor with a very nice cutter. See how quickly it cuts through metal ceramic. Finished. I've cut through the metal ceramic, so now I'm going to do the extraction of tooth number 12 to assess that maybe I'll use site number 12. So the extraction's done. I take a periodontal probe and I assess to see if I have any perforation. And the truth is I don't have any perforation, so I could use this as a site. Instead of 13, I'll use a ready site. And wherever you have lamina dura, you have nice hard bone for good primary stability. So now the starting point will be on the palatal wall to stay away from the buccal plate. So what we're looking at, I would like to be able to have the camera look in the socket. There's the apex, there's the starting point. I hope that's visible, because that's an important point. Not the apex. The palatal wall is the important. About 2-3 millimeters away from the apex. That's the starting point. Now take a 1.2 drill.
Without water?
Usually without water, so that it doesn't slide and I can see where I'm going. Let me see. Okay, I don't like the site because the palatal wall is very thin, so I'm going to go for the canine. Let's have a punch, please. So I'm aborting the lateral and I'm going for the canine. So I'm using a punch here.
Why are you using a punch?
I'm using a punch because on the scan I can see that I've got enough bone. So if I can avoid a flap so that to minimize soft tissue changes, I will do that. So what I've done is I've removed a plug of soft tissue, and I need a round burn now.
And also you have enough keratinized.
Yes, I have enough keratinized, which is important. No water so that it doesn't slide all over. Okay. Now,
how do you feel the bone of Miss Maria?
It's quite good quality. It's not, and you can see it from the scan as well, that it's a, I would call it a type 2 to 3. So now I'm using a 1.2 drill, and I'm going to let this take me within the envelope of the alveolar crest, alveolar ridge. And as you can see, this is too far labial, which I expect and I know, because that's what the scan shows, that it's going to be like that, but I'll correct it with a co-axis. So look at where the axis hole would come out, right on the incisal tip, and that's not what we want. We'll correct it with a 12-degree co-axis. So this is a 1.2. Now take a 1.5 draw. This is a 1.5, but with irrigation. And I just ride the same plane again. There. Now, I take a perio probe, and I make sure I haven't perforated anywhere, that I haven't gone out of the buccal of the palatal plate. So I'm okay. Now, this is a 2 millimeter draw, 2 by 20, 2 millimeters by 20. This is a 20 millimeter probe, and I'm 20 millimeters to the gum. I know from the scan I have 16 millimeters of bone available, 60 millimeters. So, if you have a look here, this is a straight direction indicator. Now, if I put the surgical guide, it'll just prove to me that a straight implant is not the right implant here. You see, it's coming out through the incisal. If I put a 12-degree direction indicator, you can see it's not straight. There is a difference between the straight and the 12-degree. If I put the 12-degree direction indicator like that, we've corrected the prosthetic axis of the implant by 12 degrees.
Because remember, I want to do a screw return prosthesis, so the inclination of the implant is very vital.
So this is better, but still I wanted a bit more palatal. I now take, okay, so now this is the final dedicated draw. My soft tissue height, by the way, which I'm measuring with the probe, is about 5 millimeters. So I need 20 millimeters depth, including the soft tissue, in order to put a 15 implant. I'm quite happy with that. So what I need now is a 15 millimeter long implant, 3.4 diameter, which in southern implant terms is called an IBNT 15. But it's going to have a 12-degree correction angle in it. So it's a co-axis implant.
In order to achieve subcrestal angular
correction.
To achieve.
So we will achieve the angle correction with the angled implant. The angle is built into the implant.
So I won't have to use any angulated abutment on top of the implant.
No. There you go. So this is position number 13. We're going to put a 15 millimeter implant, 3.4 diameter.
So our assistants here, Leah and Tonya, are preparing the implant.
So let's have the implant. Let's wash out the socket. Thank you. Yes.
If they have good sound, just say yes in the computer.
Can you please, if you can hear us well, if you have good sound, please say yes into your computer. We need it from our side.
Right, yes.
Με 12 καμίδες. Με 12 καμίδες, παρακαλώ. Γρήγορα όμως, με 12 καμίδες. Κλειστό και βλέπουμε. Μπορούμε να το βάλουμε κάτω. Εντάξει. Okay, it seems that a lot of people, everybody has good sound, which makes us happy, so you can hear us. So let's have a look at the implant that we're going to use. Thank you. So this is the implant. Can we focus on it maybe? There you go. If you look, it is an implant that's 15 millimeters in length. It has a machined surface cervical area, or a collar. You see that there's a part that's more machined surface and there's a part that's rough. So if you look at this area here, this here, the implant starts from here to here. This is the fixture mount, the blue part. So this part is machined surface. And the reason it's machined surface is to help minimize and prevent peri-implantitis. So here we go. It's going in very nicely. Now I want you now to look at something important. As the implant is going in, I can stop it, and then okay, have a look here. So this is the correction angle, and this is the long axis of the implant. You see how nicely we've brought the access hole to the palatal side. Okay, so now I need to keep going until I get to the right depth.
So which is the right depth?
The right depth. Can you see a black mark on the implant? Let me show you. There's a black laser mark here on the fixture mount. That's 3 millimeters from implant level. But we said that our soft tissues are 5 millimeters. So I have to bypass that black line, which I'm about to, by another 2 millimeters. I've got nice stability, very nice. I would say this is at least about 70, 80 Newton centimeters. Okay, I'm now at the depth of the black line, which means I'm 3 millimeters. Which means I'm 3 millimeters. The implant platform is 3 millimeters deeper than the gum, but we said the gum is 5 in this case. So we need to go deeper. So, and also we need to make sure that the access hole stops on the palatal and not on the buccal. Imagine if it starts on the buccal, it will make it twice as bad as it would have been if it was a straight implant. Wow, this is nice stability. I'm using an implant inserter. One more turn and we're done. There you go. So what I'll do now is unscrew the fixture mount, and I'm going to use an implant protector or a bone mill cap, and I'm going to bone mill any interfering bone there with water. Okay, there you go. So now I'll remove. Can we put a 2 millimeter abutment, please? AMC 2. Yeah.
So why are you bone milling, Costa?
So I've bone milled interfering bone that would interfere with the seating of the abutment. So that when the multi-unit abutment is placed in a minute or so, it seats properly and we don't have any interfering bone. That's quite an important point. Otherwise, you'll take your post-op X-ray and you'll find a gap between the multi-unit and the... Right, there you go. Can I press you? So let's see. Can you see anything there, Nico? Thank you. So there's the implant. Okay, so now what you are seeing here is the multi-unit abutment, which we call a compact conical. It's 2 millimeters in height. And
so basically we're converting a bone level implant to tissue level implants.
And also I can feel with this screwdriver if there is any interference. I had a sudden stop, which means there was no interfering bone. Now I need to torque this. I need to torque it to 45. There it is. Can you see this part here where my finger is? So I'm torquing the abutment to 45 Newton centimeter, and we'll never remove this abutment. It's called the one abutment one time concept. There you go, great. So I'm torquing it, it's torqued, it's not going to come loose. I'm putting a healing abutment onto it, like there. Okay, let me see how. Let me just have a look at something here. Cliste parakalo, bite. Good. Open. let's see this. The guide here, let's see where we are. Okay, the guide is in place. I need to, and look where there we go. So we are sure we're going to have screw retention. Great. Okay, so now we've done the one. Let's go on to the next implant. The next implant is going to be tooth number 16, this one here. So we need to extract it. But I'm not going to use an extraction forceps because I may risk fracturing the buccal plate. I need a fast handpiece with a cutter. And what I'm doing now is I'm cutting the crown off here. We have an excellent patient, as you can see. So, crown's off. Right. Let's do this. Get rid of everything. And now, what we need to do is drill through the tooth. So, here we go. Next one, please. 1.2. So, over here. Now we go to 1.5. Every time I use my perio probe to verify that I haven't perforated the floor of the sinus. As you can see, I've got a good stop. Next, please, 2. We have the luxury here of having good bone height. Next. Nice. Next one. Next. I still have a solid floor. Okay, before I carry on, I'm going to separate these roots, remove them, and then decide if I'm going to draw wider or not. So, I'm separating the 2 buccal roots. I'm separating the palatal from the distal buccal, the palatal from the mesobuccal. I'm now going to use an elevator, separate everything, and elevate the roots out. Thank you. So, this is the distal buccal root. Okay, let's go for the mesobuccal root. There's the mesobuccal root. There's the mesobuccal root. The crown cutter, this one here. Can we just check it, please, and we'll tell you in a moment. And we're left with the palatal root, which is this one here. Okay, let's have a look here. So I'm very happy with this osteotomy here. I've got bone everywhere. I have 15 millimeters of height. Okay, so let's use, so this is the burr that I've been using. There you go, there's the, okay, so now I want please, 515. This is a 515. Okay, what I'm using here is a 5 by 18 millimeter drill. I want to go full depth to the gum. Okay, there you go. Okay, now, just a minute, let me see what I've got here. No. What I need, please, I need a 6 millimeter by 15. 6 by 15 implant, triple BT 15. So, please have a look here. Can you see the osteotomy? Is it visible?
Mm-hmm.
Okay, we're going to show you the osteotomy in a moment with a better view. Dry, Parto, dry. Let's see if we can have a look at this osteotomy. Yes, we're showing it right now. Okay, we have another. The light has gone yellow. Πού είναι ο Χρήστος? Ο ψηλός ο Χρήστος. There you go, that's better. So let me just tell you what's going on here. That is the palatal root, distobuccal, osteotomy, mesiobuccal. Χριστό. Το φως έχει γίνει κίτρινο από άσπρο, αν μπορείτε να αλλάξουμε παρακαλώ. That's better. Okay, a bit more white. That's it. So, my suction right now is in the osteotomy side. Όχι ξαναχάλασε. Γιατί?
Όχι.
There you go. Okay, so you can see the osteotomy site right in the middle there. What I'm going to, I have slightly over 15 millimeters of height. So I'm going to use a 6 by 15 implant. I've drilled 5 by 15. 5 by 15, but I'm going to use a 6 millimeter, slightly wider for excellent stability. Let's have the implant. Thank you. Can I have it? So let's put the implant. So this is the implant. It's a 6 by 15. 6 by 15 straight implant. 6 by 15 straight implant. Here we go. Right. There. Okay, the motor just stopped. Okay. And now we will use a zygomatic implant inserter. Is it possible maybe to get the whole implant inserter in the picture? With the handle. You know there? Just so we can appreciate the size of this instrument. It's used for zygomatic implants. So we're placing an implant in the position number 16. We've got nice stability. Okay. Yeah. Wow, nice stability, yeah. And I want to make sure that the whole implant is in the bone. We don't want any threads out of the bone. We want to be slightly subcrestal, about 1 millimeter under the bone. Because don't forget, this is an extraction socket. There you go. So, what we need to do is test this with a torque wrench now. Wow, that looks nice. Makri? No? What is it? So, let's put a torque wrench on here. I'm pretty sure it's well over 45, but let's check. So, this is... So, there you go, 45. You can see that that it's not going anywhere. I go 45 and it's not going anywhere. Now, if I really wanted to know how much torque we have here, we have what we call a power wrench, which goes up to 250. It's more, it's like an experimental wrench. I'm sure this is about 100, this one here. Let's see. Okay, if you have a look here, it's exactly, the first line is 100. So it's 100 newtons. There you go. Can you focus a little bit there? There you go. So that white little tip there has gone to the 100 line. Okay, so now we remove, in actual fact, I want to go a bit deeper because we've got some buccal recession here. So I'm going to just go a little bit more. And I'm going to just torque test it again, power wrench. Let's just torque test this one more time.
Do you think that over-torquing could cause a problem?
No. No, I think that's a myth. There you go. The good studies, Paolo Trisi's study, Al-Kayat study, they show that high torque doesn't cause necrosis. So we need to bone mold this. Give me the 6mm bone mold cap, please. We need to bone mold this and put a multi-unit abutment on. After. So we put a bone mold cap on here to protect the implant. There you go. And then we use a bone milling device, which is this here. This is a bone milling drill, like this, with irrigation and there you go. Okay, so we've removed any interfering bone, and we're going to put a multi-unit abutment that's dedicated to the 6mm size implant. Naval Menadiadi?
Yes.
No. So we're going to put a 2mm high multi-unit abutment. See, all this bone must be away, yeah? I think it's important, Nikos, we want to have a look at the implant. Let's see. Anita. Can we, there you go. Can we focus a little bit there? That's it. So please note that this implant has 3 pinholes because we don't want to damage the hex with high torques. So there are 3 pins in the fixture mount that drives the implant. Let's have it, please. So this is our multi-unit abutment. It's got a 2mm collar. There you go. And we're going to torque it to 45. Never remove it. There you go. 45. Look at that. Can we show the torque here? Let's show the torque reading. Yeah, that's it. 45. Okay. And then we place the appropriate corresponding size healing cap. There you go. Let's keep that there. And what we're going to do now is put in our, and everything looks pretty good. Okay, so now before we carry on, it's appropriate now to put the lower denture back in and take a bite registration. Please step out, Carlo. Perfect. So we don't lose our vertical dimension and our jaw relation. Open for me, please. Thank you.
So we've decided to maintain the same vertical to the patient.
Mm-hmm. We use bite registration material like this. Before we remove the other teeth. Okay. Please there. There you go. She closes in the same position.
Stable position.
Stable position. Like that. Using the lower denture. Using the second quadrant, which we haven't extracted yet, and using the 2 healing caps to index the bite. This needs another 30 seconds to set.
So which are your criteria, Costa, to choose the right height of compact conical abutment? Why 2 and not 1 or 3?
We want the head of the compact conical abutment, the top of the compact conical abutment, which is a little bit like a pyramid, a flat top pyramid. We want that to be just under the gingival zenith of the buccal gingiva.
Which means it's going to create an aesthetic problem for
Exactly.
the
We
patient.
don't want
To appear, so
visible.
exactly.
So we go slightly deeper when we have extraction sites. Anichte para Carlo, Klister. Anichte, Klister, perfect. Anichte. So we remove this. There you go. Okay. You see we've indexed with the 2 healing caps. This is the one healing cap, there's the other healing cap. We've indexed that, we've got the denture, and you'll see how we're going to keep on relining this. But before we carry on, very important is now we make a new surgical guide, which we're going to index on these healing caps, and we're going to use the labial and buccal surface of these teeth as our guide. So you'll see now what we're going to do. I'm just changing gloves now. So basically we've done half the top jaw. We've done it flapless. It's not always possible to do it flapless, and it's not essential to do it flapless. We prefer where possible to do it flapless so that we have minimal post-op swelling and minimal post-op soft tissue changes, because we're going to put in the temps in about 6 to 8 hours and the permanence in 1 week. So let's take this out and let's cut this. Yeah, have a look at what I'm doing. I'm cutting here.
Just at this end.
Just a little bit so I can see exactly where the teeth are. Okay, so there's, now if I extract these teeth and I index this on those healing, I know exactly where each tooth should be. Secondly, if I extract those teeth, I have already captured the vertical dimension and the eccentric relation. So, according to our 3D scans, the next implant should be in position number 22. Why? Because position number 21 has a periapical area and it has eroded the buccal plate. So we're going for number 22. So what we do is we cut this here. This is Bravo. So what we're going to do is we're going to extract one tooth at a time. So we keep the other teeth as a guide, as a reference, as a direction indicator, like a GPS. So we've extracted. Okay, we're going to give a bit more local here. Let's see where we are here. Great. No perforation, solid buccal plate. Let's see if this is a good site. Let's go to the 3D scan just to inspect it again. It's number 22, which is slash 33. 33 is this one here. So this is where we are. We are right here. Is it visible? Slice number 33. We have an intact buccal plate, intact palatal plate, not very wide, but wide enough to put a 3.4 implant. So let's go back in the mouth here. I'm drilling a little bit more towards the palatal. So, this is a 2mm drill, and I'm 20 to the gum. I'm 20 to the gum. I know from my scan that I've got 17mm of bone. I know the soft tissue here is 3mm, at least 3 to 4mm. So I think I'm correct. I now put a straight direction indicator, straight, and obviously the straight implant is not the right implant here, because look where it's coming out of, the incisal edge. No good. It's coming out through the incisal edge. If you have a look here, this implant, this straight direction indicator is not the way we want to be. We want to have a 12-degree correction angle. So we have a 12-degree correction angle there. Let's put our key back in here.
You need to turn it distally.
I need to turn it a little bit distally. And look how nice.
So you can correct in all directions.
So I'm going to correct the mesodistal as well. There.
Yeah.
You see how nice that is? There's your direction indicator. So with 12 degrees, I've turned the angle so that I can get my access hole from the palatal. Great. So I need to draw the final drill and then put the implant. Radio. So it's going to be a 15mm implant, 3.4 with 12-degree correction angle. Okay, let's put the implant. I'm going to do a final test to make sure that I haven't perforated. I've got palatal wall intact, buccal wall intact, apex intact, not through the nasal cavity. Everything's fine. So let's just make sure everything's nice and dry and clean. So we have our implant here. Let's look at our implant. This is a 15mm length implant with a machined collar.
The apical, the coronal 1/3, it's smooth.
Yes, it's the same. So let's put the implant here. It's got a machined surface collar as well. Okay.
Up. Up. Άλλο από. Λίγο από.
So now I'm 3mm below the gum. I need another at least 1 or 2 turns. Okay, let's just see what stability we have. So this is 45 Newton centimeter stability. We have our access hole there. We have our long axis of the implant there. So that's the correction angle. No problem. So let's remove this fixture mount. Let's bone mill and place a multi-unit. Use a 1. Multi-unit 1mm. So let's bone mill this. Okay. Thank you. Make sure no bone is left here. Λίγο πίσω το κεφάλι, πίσω. Έτσι, μπράβο. Is that more visible in the camera? Πιο πίσω, έτσι.
Ευχαριστούμε, κυρία Μαρία.
Okay, there's the hex. You can see the external hex. You can see the platform. It's clean, dry. There's the multi-unit. Goes in here. I just need to look at something. Take this out for a minute. Nico, I want to show something important here. Is it possible the camera can... So, the height of this multi-unit must be just under the gum. So when we look at it from this angle, you should not actually see the multi-unit. Then you know that it won't become visible later. Give me the cap. I want to see something.
Check with the key inclination.
Yeah. Give me a narrow cap just for now. There's more.
Let's see the inclination with the key.
Petros.
It's perfect for me.
Okay, that's good enough in terms of screw retention. It's palatal, but I'm not sure if it's good enough in terms of depth. If you look at this, it's much deeper than this. So I think we need to go at least one turn deeper. Okay, so we're going to go deeper.
Which means that he has to remove the compact conical abutment.
There's the compact conical, the multi-unit. I've removed it. I'm putting back the fixture mount. And I'm going to go, in actual fact, 2 turns. Each turn is 0.6 of a millimeter. The pitch of the thread is 0.6. I want to go 1 millimeter deeper, so I'll go 2 turns.
And if you think three-dimensionally, the deeper you go, the more palatal you go.
Yes, also. That's important. The deeper we go, the slightly more palatal, which suits us.
Exactly.
So that's 1 turn.
You need to be very careful not to strip the hex of the implant.
Okay, there's 2 turns. But now we need to bone mill again, because remember, now we're deeper. There you go. Take that out. There. Bone mill with extension. Thank you. Okay. So there we go. Healing bone mill cap removed. Remove bone debris, bone chips here, and give me the abutment now, a multi-unit. Yeah. So. Upper. Πάμε πάλι εδώ. So I'm going to torque this now 45. Good. I don't think I can put this wide healing yet because it's interfering. So what I'm going to do is I'm going to put it on later. I'll put a narrow one on for now. Let's have a 6 millimeter narrow one.
We like the wide ones because they keep the soft tissues open, and it's easier for me to place the prosthetic work later.
So now we've got to remove this tooth, number 4, and place an implant here. Let's just go to the X-ray now. So what we need to do is go to, let's go to the panoramic first. So there is tooth number 4. I want to go at an angle like that, to avoid the maxillary sinus. I could go further back here, but then I have to put a shorter implant. So I'd rather go like that, and which is slice number 39. Number 39, there it is. There's slice number 39. So I've got good height. I've got intact buccal and palatal plates. Here it is, number 39. That's where I want to put the implant. Okay, let's go back to the mouth now. We're going to have to cut this bridge. Okay, so we have a loose tooth here. Never mind. Modality. Okay, actually there was no point in cutting that. That was a cantilever. It was a pontic. Digo to picotele. So let's number up a little bit more here. So we need to remove this tooth here. So crown's off, but roots are still there. Let's have a straight hand piece, please. Straight hand piece, please. Fladdy. Let's see if I can put this. No, still can't use it, so I'll use the narrow one. 6. Thank you. There. Let's have a straight hand piece. Separate this. It's a 2-rooted premolar. Okay. So I've separated the buccal from the palatal root, and I'm going to use this very useful instrument with a very sharp tip.
What's the name of that?
It's a Q3D instrument, and I can give the code to whoever wants it. We call it Tonya. There, and we still have the palatal root there. Antonio. There it is. There's the palatal root. Okay, so the tooth is out. And we're going to go for the palatal root socket. There. Maybe you can look inside there. Is it possible? In there. We're going to start there. So this is a 1.5 draw. I'll start like that at an angle. Remember, we want to avoid the sinus. So we want to go at an angle like that. There. I'm 20 to the gum. There you go. This is a 12-degree direction indicator. It's not straight. It's got 12 degrees built in. So I'm going to correct it mesiodistal, not buccopalatal this time, mesiodistal. And let me put my key here. I can even correct it palatally. There, I can bring it more palatal if I want. There. Okay. Now, if it was a straight one, look at the straight. It's coming out to buccal, and it's coming to distal. The distal, it's not so important. The to buccal is the problem. So we want to definitely use a coaxial implant with 12 degrees. There you go.
Could you use a 24 degrees here?
No, I think I'll manage with a 12. Okay. So what I need, and in actual, and we're going to have 2 cantilevers on this side. So I'm thinking maybe to to use a 5mm diameter implant. I think I can fit a 5mm. So this is the site that we, number 39 slice is where we are working, and the diameter here, or the width rather, is like 6mm. So we'll use a 5mm implant, but remember it tapers, so it's 5 only right at the top. So what I want is a 5 by 15 with 12 degrees. So it's a co-axis, 12 degree, but it's going to be a 5mm diameter. And the reason is I want to use a strong implant because we're going to put 2 cantilevers. We don't want it to fracture. There you go. Oh, and by the way, no sinus involvement. I'm palpating with this perio probe. It's a 20mm long perio probe. I'm palpating everywhere. I don't have any sinus exposure. Let's go here. Let's wash out. Let's do this one. So, let's look at this implant. It's, I want a co-axis, please. 12 degrees. Give me a 12 degree. Co-axis, please. Leave it almost. Okay, we're going to place at 5 by 15 with 12 degrees, which corresponds to this direction indicator. There you go.
Costa, what about overloading the bone with an angulated implant to cantilevers? Are you afraid of that?
Not at all. The good 3D finite element analysis studies that shows there's no problem in terms of stress and strain. Let's just wash out one more time. There you go. Right, and now let's look at our implant. This is our implant. Okay, it's 15 millimeters in length. It's 5 millimeters in diameter. It has a 12-degree correction angle. You can see the access hole is from the side, and it's machined collared, which means it's suitable for patients that might have a perio tendency or periimplantitis. So what we do is we put the implant at an angle like that. Okay. So now this is going in quite tightly, which is what we want. I'm going to need to tighten this fixture mount in a moment so that it doesn't come loose and to damage the hex of the implant. So what I'm doing here, I'm tightening that, and now I'm using a heavy-duty inserter, the zygomatic inserter. You see the black line? That black line must disappear under the gum. It's disappearing, which means I'm 3 millimeter below gum level, and I need a millimeter or 2 more because it's an extraction site. We're going to put a multi-unit. Last turn, and we're done. There you go. Maybe slightly more. Torque wrench. So let's put the torque wrench on here. 45, it's not going anywhere. Look, solid as a rock. Let me put this here. You see, I can't put it on because I need to first remove the
implant mount.
There's the implant mount. Let's put a bone mill cap now. There's the bone mill cap. So I can do the bone milling, but before I do that, let's check the position. Now, watch this. There you go. There.
Good enough for me.
Okay, so let's bone mill this. Bone milling here now. I would like to go one more turn. I want to make it slightly deeper. Fixture mount, please. Thank you. Tighten this. And let's do it with this here. Let's remove this. Okay. Let's bone mill it again, please. Thank you. I've gone slightly deeper and I've also gone slightly more palatal. Because the deeper you go, the more palatal it goes.
And mesial here, Costa.
And more mesial, correct. So let's have a... no, just a minute. Question. Should we platform switch this one or not? Well, this is a 5mm diameter multi-unit. If I place this one here, then I'm not platform switching. Personally, I think that
this is number 4,
so
it's going to be a premolar.
So this is a bit wide for a premolar.
Yes.
So let's platform switch it.
But on the other hand, there's the question of 2 cantilevers at the back.
Correct. Let me, before I talk it, let's just have a look. Let's see. So have a look at where it's coming out of. There, right there, which is nice.
It's perfect.
So it's, let me just see in relation to the Part1. Yeah, Christian. Okay, open. Okay, what we're gonna do is I think we're gonna platform switch this. I prefer a platform switch. So let's put a we're gonna put a 4mm multi-unit on a 5mm implant.
So what's the disadvantage of placing a 4 platform switching now?
The prosthetic stability isn't as good as a 5.
Which the truth is that we never see loosening of our abutment or of our prosthetic work, even with 2 cantilevers, if they have passive fit. So now you're using a gold compaconical. What is that, Costa?
I'll tell you in a moment. Let me just get it on. This is a titanium nitride coated multi-unit, something very new. It has a submergence emergence profile. Let me just. It's a little bit different to the original multi-unit. It has a submergence.
It's more concave.
There's a concavity here, which is more tissue friendly as compared to the traditional one. So just wash dry
and it means that you don't need to bone meal as much.
As much, yes.
But still you need to make sure that all the bone is removed in order to have perfect fit of the compaconical onto the implant.
Suction, suction.
Oh, be careful. No, it's here, it's here. It's here.
Okay, here we go.
I think it's the path of insertion.
I have an issue here. I need to bone mill one more time, please. Yeah. Yeah, Petros. Bone mill cap. Actually, I don't need to bone mill. It was my angle was not the right angle. Give me the abutment. Let me put it. Multi-unit, please. Clean and dry.
Nice.
Right. Torque.
45 Newton centimeters always.
There you go. 45 Newton centimeters. Okay. And let's put on our healing cap. There you go. Good. I'm happy with that.
Let's take an impression now, Costa.
We need to take an impression because it's nice to index a key with existing two teeth so the lab doesn't get lost in its setup. Small. Use a small. Pull it up. This here goes there. Okay. We can work with that. We can work with that position. We can work with that position for screw retention. So there's the key.
Open, please.
The purpose of this this impression, Petro?
It's to relate the front two teeth to the position of the implants, because we don't want to remove them before we, because we know their position, so we would like to relate them to the.
So you want to maintain that position?
I know how long they are. I know that I have to lengthen them for about 2 millimeters. So now I can relate them to the healing caps, and the technician knows exactly how much to lengthen those teeth, knows exactly where the position, the initial position is. So I'm making his life much easier. If I would remove those teeth without taking an impression, the technician wouldn't know exactly where to place the lateral incisors, where the central incisors, where the midline is, the inclination of the midline. But now he will know. I need to wait for another half a minute.
So what's left to do now is to extract those two front teeth. Well, it's actually one tooth. It's one tooth plus a cantilever. Yes. Extract that tooth, place the the wider healing abutment on the implant number 22, and take the reline or add onto the bite registration and take the impression on the top and then go to the bottom.
And give me 10 seconds.
Okay, so now the next thing to do here is to extract this here. Okay, done. You can see the periapical granuloma here. The periapical granuloma, which we could have predicted it from the scan. So we throw this away. We change this healing cap. Put a wide one. Can I have the wide healing cap, please? Healing cap wide. Thank you. So this is now the ALL-ON-4 Nicolopoulos.
Preston.
Yeah, wide but narrow. Thank you. So, what you see here now is an ALL-ON-4 flapless using guides like this and like this. And what we need to do is put this original, the first bite registration there. There you go, it clicked into place. Please, Parakallo. There you go. And what we need to do, this is quite important, we need to add, there's the Felis Abapano, Nico. Το κεφάλι πάνω και κάτω. There you go. We need to add bite registration material. Για κλείστε λίγο. Μπράβο. So we take the bite registration material and we add it here. So we can capture the other two healing caps. Very nice. So the next thing we do now is once this sets, is take an impression. We're going to take an impression using open tray impression copings, and then go to the lower jaw.
No, we need to take a recording with the face bow. With
Okay,
laser
so
face bow,
I left out a prosthodontic step is a face bow recording.
which is very important.
They say it's very important. Sonia, you have to look that side. Please, παρακαλώ. Now, we can see, look, she closes spot on. No problem. Ανοίχτε παρακαλώ. So we remove this now. Βγάλω το και αυτό. There you go. Have a look here. We have 1, 2, 3, 4 healing caps which have been indexed. Okay, so in actual fact, you can even now separate this because I want to use the denture. I want to use the lower denture, which has holes, as a guide for the lower. So we have our bite. Okay, now let's take the impression and then we'll do the face bow. So, have a look. Yeah. The nice thing about this case is we've got good primary stability on all the implants.
We're having an excellent patient as well.
There you go. Yes, sir. No, I mean, so this is a wide, which goes here. This is narrow, which goes here. Next narrow one goes here. And next narrow one goes here. So we have 3 narrow, 1 wide. Next. So make sure these are nice and tight. They must be tight.
If you're not sure about them sitting perfectly, you need to take
Okay,
reapical x-rays.
that one. Can we have another impression coping screw here, please? I'm not happy with this one. There's something, another impression coping screw. Yes.
We need just the screw.
Just the screw. Thank you. So there you go. So there you go. Nice and tight. Let's have a look at them. Look how nice and parallel they are. They don't need to be so parallel, but with 12 degrees, you usually get them fairly parallel. So now we take one of these trays and we break some holes in them. So this is number 2. Let's go to number 2. You see, I just broke that one. That one's number 434. There you go. This is number 3. 1, 2, 3. And this is number 6. 4, 5, 6. There you go. Now, I may have to still make some adjustment. Let's see. That's fine. That's fine. This one needs a little bit distal and buckle. Let's see. So let's just break that there. And there you go. Let's see now. So we've made a nice open tray in about 1 minute. There's the open tray. You can see it there. You can see impression coping screw, impression coping screw, impression coping screw, and impression coping screw. So we're going to fill the tray and we're going to fill the mouth. we're going to fill the upper jaw and around the impression copings with a very hard impression silicone material, which is actually bite registration material with a very high shore hardness value of 54. So these must be nice and dry, no saliva, and off we go. So look at this here. This takes 1 minute and 20 seconds to set. So we've got to be fairly quick here. There you go. Perfect. I've got all 4 holes. I've got all 4 impression coping screws through the tray. We don't always get it right, but this one's going perfectly right. The important thing is to use material that's quite hard so that the impression copings don't move in the impression material, and also because we have usually more blood than this, you don't want 6 minutes setting time, you want quick setting time.
It's also the comfort of the patient.
Yeah. So we're almost done with the top. Tell us, Petros, about the what you're going to use the face bow.
We're going to use a face bow, which is from Part1, Zone Cois. It's a face bow which has 2 laser beams. With one laser beam, we're going to be able to locate the midline, and the other laser beam we should in such a way so it's parallel with the Camper's plane, the allatragal line.
So it's more a dentofacial analyzer, midline and occlusal plane type of.
It's a kind of face bow.
Yeah.
It's going to help us to mount the upper implant model in such a way so it's parallel to the plane of occlusion, parallel to the floor. The midline is exactly where it should be placed.
Okay, so now we are 1 minute and 40 seconds. This needs 1 minute and 20 seconds. So we waited 20 seconds extra. We know it's quite hard. We unscrew the impression coping screws. I like using these long screwdrivers, make my life easy. As you can see, even in the position of the 1/6, it's easy to work with long extraoral screwdrivers. Look at that. There you go. And here. There. So we've unscrewed all 4 now. And here we go. Have a look here. These things are rock solid. Nothing's moving here. They are very nice and stable in this material. Okay. Okay, so that's done. Let's put on our healing caps now. Let's have the healing caps, please.
There are different kinds of healing caps. You need to be sure what kind of healing caps you are using, because you need to give the same to the technician, because he's going to be mounting the case, and if he's going to be using different kind of healing caps, then the mounting is going to be wrong.
We make sure that things are nice and dry and clean. We don't want gum or not even blood, if possible, to be lodged between the healing and the... Let's have the next one, please. And one more. So, you'll see here now we have 1/6, 1/3, 2/2, 2/4, and we'll have 2 cantilevers. So on the one side there'll be no cantilevers, on the other side there'll be 2 cantilevers. Nothing wrong with that. So now let's do the dentofacial analyzer, the type of face bow. Not really a full face bow, but it's very helpful. Let's do it.
Yep. Let me change my gloves.
While we're waiting, I'm going to do a bit of local anesthetic on the lower. So we want to work in this intermental region. I'm just going to infiltrate. I'm not going to give a block here. Φαίνεται το κάτω. Yeah. So. Okay. Gazula. Καθαρίσουμε λίγο. Το πάνω το τελειώσαμε και πήγαμε τέλεια.
Βοήθησέ με.
Πολύ ωραία.
Ανοίξτε μου το στόμα σας.
Εντάξει.
Βοήθησέ με.
Λοιπόν, μισό λεπτό Πέτρο, μισό. Χώσου. Περίμενε. Θες να το βάλω αυτό, είσαι εντάξει. So what we need now is we need to check the midline is correct. Λίγο πιο μακριά για να φαίνονται.
Ναι, look at the campus plane, Costa.
And ALL-ON-4 line parallel to this and ALL-ON-4 parallel to that. That's parallel. Midline. There. That's it. Midline's correct. Interpupillary line parallel to the plane of this dentofacial analyzer. So let's go through it again. This plane here must be parallel to the interpupillary line to get the occlusal plane reasonably parallel with the horizontal. Midline is a laser line. It's not very visible because of the light here. There's a laser line here so that we can get the midline correct. And then we want this to be parallel to the ALL-ON-4 line here. And we want this to be parallel to the ALL-ON-4 line on this side. Okay, so this is the laser track dentofacial analyzer by John Coyce. He's the designer of it, Coyce, John Coyce. Okay, I think it's set now. No, it's set. So, you want to explain here now what you have?
Okay, those are the healing abutments. Would they fit exactly here? And we're going to use this mounting table, which you can separate from the face bow.
Just do it again, Petros, because it wasn't visible. Click it on and click it off again.
Okay. So we remove that from the mouth, and you can see here the healing abutments. 1, 2, 3, 4. You can remove that from the face bow, and now we're going to use that in order to mount the upper implant model with articulator.
Okay, so now we finished completely with the top, and we go to the bottom. It's exactly 1.5 hours since we started. So, let's clean our very cooperative patient, which we appreciate very much, up a little bit. And we'll carry on with the bottom. Thank you very much. You are a great patient. Very big help. Thank you. So, there's Monico. So, we have a 5-minute break for questions. Fantastic. Θέλετε κάτι? Βεβαίως. Δώστε μας 2 λεπτά, σας βοηθήσει τώρα η Λία. So, Nico. Okay. Okay. Am I on air? Can they hear me? Okay. Once again, thanks guys for participating in this webinar. I'm going to answer some questions. The first question is from a very good maxillofacial surgeon friend of mine from the UK, Louis Bruzel. Hi Louis, and the question is, can you send the platform switch code that you used? So the multi-unit abutment which I used is called an AMC1. AMC1. It's a multi-unit abutment that is normally used on a 4mm implant. In this case, it was a 5mm implant, but I used the 4mm multi-unit abutment with code AMC1. That's the Southern Implants code. Next, can I have the next question? I answered Louis, which was right on top. Okay, the next one is from Evangelos Kotsogiannis. Γεια σου Ευάγγελε, and I'll read it in Greek and I'll translate it. Ήθελα να ρωτήσω με τι χειρολαβή και φρέζα κόβεται τη γέφυρα. The translation is, Evangelos would like to know with which handpiece and what burr, what drill do I cut the ceramo-metal bridge. So the handpiece that I use is a W&H red ring. It has a red ring around it. It's a speed increasing handpiece. If I remember correctly, it's a 3-to-1 or a 5-to-1 increasing. 3-to-1, yeah? It's a 3-to-1 increasing handpiece, and the code is WS-92E/3. I'll repeat it. WS-92E/3 by W&H. And the burr is a crown cutter. It's by Comet, K-O-M-E-T. It has a very long reference number. It's like almost like a passport or something. H4MC XXL314014. I'll repeat it. It's by Comet, and the code is H4MC XXL314014. The next is by Ramiz Chaudhry, the periodontist from New York. He says, Dr. Costa, it's Ramiz from New York. I'm sorry, but at what talk do you make the call to load? Ramiz, a guy by the name of Paolo Trisi, in a recent publication in JOMI, I think it was January this year, 2017, did some research, and his conclusion is that if you have a ISQ value of 68 to 72 and an insertion torque value of 45 Newton centimeter, you can load immediately. What we use is we don't use an insertion, we don't use an ISQ because we simply don't use the resonance frequency measuring device. We just use the torque wrench, minimum 45 Newton centimeter. So we like to have a minimum of 45 Newton centimeter. If we don't like to immediate load. I hope that answers the question, Ramiz, and thanks for your question. Then there's a nice comment from Eleni Katsaiti. Thank you, Eleni. You said magic hands. Thank you very much. Then Dennis Kristofovich, good evening. Looks very easy. Which torque was for the implants? 45 Newton centimeter minimum, but I'm sure in this case, due to the good quality of bone, I'm sure we had like about 70 Newton centimeter in most implants. In actual fact, in one of them, we had over 100. That was the 6mm diameter implant in the 1/6 area. Then Eleni Samu says in Greek, and I'll translate it, υπάρχει κάποιο βοήθημα για την τοποθέτηση με σωστή εγγύς από κλίση του co-axis εμφυτεύματος? The question is there some assistance, like a direction indicator, something to assist you with where to stop the coaxial implant. And the answer is the guide, that silicone guide, that key that I used is a big help, and also the 12, 24, and 36-degree direction indicators. I only used the 12-degree direction indicator in this case, and that's because it's not an extreme case, so I wasn't going to use 24 or 36 degrees. Then Theo Odysseus from Nicosia in Cyprus. Hi, Theo. What is the advantage of using angulated implant with straight multi-unit versus straight implant with angulated multi-unit abutments? Well, good question. Why should we use a coaxial implant with a subcrestal built-in angle correction and not just use a straight implant with a 17 or 30-degree multi-unit correction angle abutment? And the answer is as follows. Number one, a multi-unit 17 or even worse 30-degree abutment requires more prosthetic space than a 1 millimeter straight multi-unit. So there's a prosthetic space issue. Number two, with a little bit of recession, the 17 or 30-degree multi-unit becomes visible and becomes an aesthetic problem for many patients, especially in the aesthetic zone. And that is because an angled multi-unit abutment has a minimum requirement of 3.5 millimeters of vertical height. So it's an aesthetic issue, and it's also a prosthetic space issue. And the last reason why we don't like using them is because, especially with a 30-degree multi-unit abutment, the amount of titanium around the thread of the prosthetic screw channel is so thin at one point that these things notoriously break open. And that's a problem. When they break open, we have to replace them, etc.
Can I add something as a prosthodontist?
Yes.
When you have multi-unit abutments which are with an angle, the forces are in such a way exerted to the screws that those screws are very easily getting loose, as opposed to the implants which are angulated, where the forces are perpendicular to the force, which to the screw, which means that they are not getting easily loosened.
Theo, that is a very good point that Petros has just mentioned. I have your contact details. Of course, we know each other from a while. I'm going to send you the 3D finite element analysis regarding what Petros is saying, which shows that you need a greater load to unscrew the prosthetic screw when you have a coaxial as opposed to when you have a straight implant.
I don't remember exactly the numbers, but on an angular implant, you need a coaxial implant. You need more than 1,000 newtons of load for that screw to get loose, as opposed to 285 newtons.
Correct.
For a.
Yeah. I'll send that to you. Okay. Then Shun Sursdi, hello, Dr. Costa. Tell me, please, what kind of anesthesia you use on this case from Cambodia. Hi, Shun from Cambodia. We use articaine, local anesthetic, with 1 in 100,000 adrenaline. So we use articaine. The one that we're using is actually Septonest, but it's articaine. It has 1 in 100,000 adrenaline. Then the next question is, or rather, before I go to the next question, the advantage of articaine is it works extremely fast, like within seconds. The disadvantage, it wears off fairly quickly. Then the next one is, let me just go down here, from Spiridon Nicolau. Congratulations, very helpful video. I just graduated. So Spiridon says he just graduated, and this video is very enlightening, and you explain everything simple and clear. Thank you. My pleasure, Spiridon, and I wish you a bright future in your career. Sotirios Michalaki says you put a 5 millimeter implant in 6 millimeter bone in place 25. Is the bone enough to do so? Correct, Sotiri. I placed a 5 millimeter implant in position 25 where there's only 6 millimeters of bone. Yes, 6 millimeters of bone, but remember the implant I placed is a tapered implant. So it's 5 millimeters at the platform or implant level, and it becomes 2.5 millimeters to 3 millimeters at the apex because it tapers. So the truth is you don't have 2 millimeters of bone everywhere, but you do have 2 millimeters of bone surrounding the implant in sort of 80% of the implant. And also our platform switched that, and that's a nice built-in factor to prevent recession. And another good point here is that this patient has a thick biotype. So if we add all that and the fact that I've placed the implant deep enough, I think we're going to be fine. Then from Lazaros Touranis, hello Dr. Nicolopoulos, and thank you for the nice presentation. Why did you do the denture with holes in the beginning? Thought you would pick them up in the mouth where the dentures made in duplication of the initial situation. Yes, we could have duplicated the denture, Lazaro, and made the holes in the duplicate denture, but there's no real need here. We're going to use the denture as
we're going to throw the denture anyway.
as a guide, and then we're going to take a normal impression. We're also going to use the denture for the bite registration, and in a matter of 6 to 8 hours, the patient's going to have her provisional teeth. So there was no real need to duplicate the denture. Then Theo makes a comment, outstanding presentation, world-class execution. Thank you. Thanks again, Theo. And Sankaran Naidu says, hi Costa, you and your team are amazing. What impression material are you using? And that's Dr. Sankaran Naidu from South Africa. Sankaran, we're using a thing called Stone Bite by a company called Drewe, D-R-E-W-E, from Germany. It's extremely hard, probably the hardest material in the world. Maybe there's something else similar to it. It's got a D-Shore hardness of 54, and I'm pretty sure you can get it in South Africa from whoever represents Drewe, D-R-E-W-E. In Greece, it has been private labeled with Southern Implants, and it's made by Drewe for Southern Implants in Greece. If you can't get it in South Africa from Drewe, Southern Implants Greece via Southern Implants in South Africa will be able to help you. If you're in the Natal region, Leanne in KwaZulu-Natal certainly can help you. Leanne from Southern Implants in KwaZulu-Natal. So thanks, guys. We're going to now go ahead with the lower jaw.
Δεν εξήστε. Δεν πονάτε.
Χρήστο, θέλω να πονάξουμε τον Νίκο.
Μπράβο σας, τέλεια στενής.
Okay, so we're back with our patient. We put this horseshoe type retractor here. Τι είναι είναι αυτό εδώ τώρα? Τι είναι αυτό εδώ? Λοιπόν, θέλουμε λίγο την κάμερα. Ναι. Okay. Okay, so this is our so this is our lower ridge here. We have nice attached gingiva. So this is nice attached gingiva here. Very positive feature for this case. And we want to work in this intermental region. This horseshoe retractor, which I'm going to remove and replace, is a very useful retractor. It's available from Southern Implants. Okay, it's actually my claim to fame. It has my name on because I kind of designed it when I was a registrar, a resident at the university at Wits in South Africa. So let's put our denture in. There's our denture. And this is position number 4. And this is position number 5. I'm going to just, with my probe, another Petros. Yeah, that's about 5. There you go. So if you have a look here, you can see a dent that I've made. Is it visible? There it is, there. That's position number 5. So what I'm going to do is I'm going to split the attached gingiva. How's the visibility? Are we okay there? So I'm splitting this attached gingiva here. In actual fact, can I just show something important on the X-ray? Can we go to the panoramic X-ray? How do I know that I can go to position number 5? Can you see this white area here? That is some composite which are placed in position number 4, in position number 34. That's composite. Can you see the mental foramen? So if I go to position number 5 and I go straight down, I'm just in front of the mental. So I'm going to go position number 5, tilt it slightly like this. I don't have to go extreme angle, just slightly, and I'll be in front of the mental. So the mental here is number 55. Go to number 55. 57. So can you see the Canada? Okay, so this is the left mental foramen. I'm going to go around about here. Can you see it's a bit knife edge? So we'll trim it, we'll table it a little bit. So let's go back here now. Okay, so now I've made my incision. I've split the attached gingiva. Okay, there you go. And there. Now, what I need is an instrument like this Lucas excavator on this side and something similar on the other side. The important thing is not to tear anything here. So we don't do a lot of retraction, just like that. So I'm using now a round burr just to flatten it a little bit. Okay, so now you see what happens when you use water? You slip. So there's no need with a round burr to use water. You're going to draw all that bone away anyway. So there I am. To check if I'm in the right place, I put this guide, which is the old denture, back. I go into that hole. Look where I am. Exactly position. Number 35. Let's see. Yeah. Αυτό το δάχτυλο λίγο. Όχι. Let's see. Let's see. Right. So we position number 5. I'm not to buckle. That would be wrong. I'm there, so we can get nice screw retention. And in actual fact, what I can do is I can even do this. Look. Now that I've made my starting point, there you go. Put some water now. There you go. So let's get out of here and let's see if everything's okay. Right. Look at this. There you go. I'm 13 with this superior probe. I want to go. According to my scan, I can quite easily go. We don't know. I can quite easily go 15 according to my scan. So let's go to the next one. This is a 1.5 now. You must. Someone's in the way here. Who's in the way? I'm in the way. Okay, I'll get out of the way. Further, just change my suction.
Sorry.
Το δυο μακρύ. Όχι, εσύ είσαι εντάξει που είσαι. So, this is now a 2 millimeter diameter, 20 millimeter length drill. So that's 7, 10, 13, 15. There you go. This is a 15 millimeter probe, and I'm about 16. Okay, so we are doing very well. Next one. Actually, before we carry on, let's use a straight direction indicator. Let's put it there. Let's take the denture. Let's put the denture there. Beautiful. Can you see, Nico? Is it visible? Okay, what if I take the mirror? Let's see if this gives us a nice picture.
Όχι.
Δεν φαίνεται,
Έτσι όπως.
Όχι. Τσακ.
Θα δείξει.
Okay, μισό λεπτό. Θέλετε να δείξετε κι άλλο? Όχι. We're happy with the position. Let's now do the final drill and put the implant. Εδώ και εδώ, έτσι. So this is now our final drill, which is a 3.something, 3.4 by 15. Let me see. I want to show the intact buccal wall or plate. There you go. There. So I don't have any fenestration, which is nice. And I have a depth of 16. Leah, that's a 4 millimeter by 15. Let me drill a little bit here. This is hard bone. I'm going to drill with a 4 millimeter drill as well. This is pretty hard bone. So this is now a 4 by 15. Okay, let's put the implant. Have you talked it, Leah? Thank you. Okay. If you look at the buccal wall, I'm about a millimeter lower. So I've got to get the implant in all the way down. So this is again an MSC implant, which means machine surface cervical or collar. Okay, let's put the implant in now. Support rubber. Okay. You can see those black lines. Those are our reference points. The first black line is implant level. The second black line is 3 millimeters from the implant level. So the first black line is where the implant, it's going in very nicely with very good stability. Petros. Can you see that second black line? That must be under the gum. That one must be under the gum to give you 3 millimeters of biologic width at least. Nice stability, very good. I would say about 100 and something. Let's have the power wrench. Let's see what we get. So we reset our power wrench back to 0, and we put this here. Okay, it's about 1 How much is that?
200.
200. I don't want to go more because I may damage the hex of the implant. So,
Or you ratchet.
or the ratchet. So I've unscrewed now the fixture mount. There you go. Now we need to bone mill. There and there. There and there. So we have the bone mill cap and the bone mill all one in the other. We go there. Then we remove all the interfering bone. Now we reverse, remove, good. AMC1, we're going to put a multi-unit, straight multi-unit here. I'm going to put a 1 millimeter multi-unit, and if I'm not happy, I'm going to put a 2 millimeter. These are titanium nitride coated multi-units with a submergence profile. Galton? What do you think, Petros? I think it's okay.
It's okay.
So, let's talk this now. To 45. There you go. 45 Veneta. Let's wait. There you go. 45. And now we're going to put the cap on. Suction this little black spot there. That's it. We put a healing. Notice the shape of this healing. It's nice and wide so that when Petros removes them in a few hours, the gums don't collapse immediately, so he can get the immediate loading structure in. Now, what we need to do is we need to maybe open this denture up a little bit, yes, because it does. This is wide, so it doesn't fit. It doesn't quite fit through here. So I'll need a straight handpiece with a big acrylic type burr.
What you could do, Costa, you could use the thinner
Yes.
abutments. Take a bite instead of grinding.
Okay, so what Petros says, which is right, let me use thinner healing abutments.
Just for the bite.
Just for the bite, and the patient will leave with the wide ones. So let's
so
remove
there is
that.
less grinding involved.
Less grinding involved, and so let's take this one out here. So I've removed this wide, and I'm going to put a Volumina HMC6. You see, this one is much thinner. So now this should fit in. I need to open still a little bit, please, but I'll have to open less than what I would have. Great. So what I'm doing is I'm using this straight handpiece with this burr just to open up a little bit here. Now it fits nicely. Okay, and let's have a look at